Nair, who's our oculoplastic surgeon, who's made this consent. Now, what if the patient can do is you send this PDF to the patient. The patient can take a screenshot of it on his phone. Then he can use a digital pen and sign on it and then send it back across to you. He can put his name, signature, and date and send it across. If he's using a laptop, he can use an ADOP reader and sign it. So that's important. Once you've got your consent out of the way, the next thing is payment. Of course, you need to know that your time and your services are being compensated for. So you can get the payment out. You can use any of these, methodologies. Your staff can handle it for you. You can do it yourself. Once the consent and the payment is sorted, you come to the actual consult. Now, the actual consult is of various, also has various arms in it. You actually set up the consult, like the time of the consult, send and notify the same to the patient, the actual consultation in itself, and then giving out the prescription. So let's look at each. Now, of course, the scenario is different if it's a different practice, like I've already talked about. If there's a single doctor run practice who has no backup in the hospital, what he can do is he can ask the patient to take photographs of the eye and send it via message. And once he looks at the photograph, then he can have a video or a WhatsApp call with the patient. Now, the patient can take the photo of the eye either himself or the relative can do that. You can have the patient even look at various gazes and take a picture. These are real-time pictures which the patients have been sending to me over the last few weeks. On the left-hand side is a patient of adenoviral conjunctivitis, and the right-hand side is actually an old patient of mine with allergic conjunctivitis. You can see there's like this, the limbal nodule out there because of the VKC. So you can see the pictures are very clear, and these are the left-hand side is a new patient, the right side is an old patient, but these are very good pictures to go ahead with treatment. This is another patient in the last 2 weeks where he sent this picture. When the minute I looked at the cornea with the blackest spot in between, and I have seen this patient previously, so I knew that this is now the infiltrate has perforated. We sent him across to the hospital where the glue BCL was done for him. This is the patient on, again, the same patient, but on the right side is another patient with glue BCL, which I had, I glued him a few weeks before the COVID started, and he sent a picture of his eye just to say that he's doing well. So, you can even see that this is the patient has sent these pictures fairly clear. Now, the patient has no relative. He can take the pictures himself. At worst, he can do a selfie. Don't really recommend the selfie. These are a few guidelines where you can stand in front of the mirror. The patient uses not the selfie mode, but the back camera mode and points the camera towards his face. And then he takes the picture. You can make a note of these. You can send it across to the patient. And like I said, if he's not able to do any of this, let him just send a selfie to you. Now, if you have a backup where you have a technician, like in our hospital, as Sir's already talked about, we have an optometrist who's been there for the entire duration. You can send the patient there who can take pictures and send it to you. This is a trauma patient, as you can see, send pictures, which is very clear pictures, on our digital camera. This is another patient of follow-up where, again, like looking at pictures like this, you may not really need to go to the hospital in the immediate future. Someone sending you, this is my corneal graft. You can see very, very nice picture sent. This was in fact sent today morning. No staining at all. Patient's doing very well. We just continued his medication, and also the EMR was sent to me via email. Now, if you do not have a slit lamp camera, if you're a very small practice, do not worry. You can just either you can ask, you can have your technician buy some magnifying lens like this. You can buy it yourself and give it to them, and this is how they can take really good quality pictures. Now, coming to the last part of it, that is what if you are using an app for the consult. We have started using a telemedicine app. We are still, kind of learning the ways of that app. So this is how it is. They send you a link on the left hand side, as you can see, with a password. On the right side, you can see there's actually the consult happening with the patient. And what is the advantages of teleconsult is, especially if it's an institute, then the advantage would be you don't want to do a WhatsApp video call because you don't want any of the personal information of the patient or the doctor to be exchanged for one. You want the admin to be in control as to what's going on. Also, the advantages are that you can share, like you can write your prescription directly onto the app and then put your digital sign and send it across to the patient. You can set up one consulting room per patient, and automatically you can then that message directly goes to the patient and you come online at the same time. Like I said, this is a hyperlink which is then emailed to the patient and to the doctors. You can also see what is your list of appointments or consultations once you log in with your password. It's very easy. And the big advantage is that I'm just going to skip through this. Another big advantage is that you can record it. Each entire consultation can be recorded, which I feel is very important for medical legal purposes. If you want to record that this is what you saw, this is what you told the patient, and you can have even the patient's relatives, say the patient's relatives now in the lockdown in some other part of the world or the city, they can also enter into the login at the same time, which really helps to assure and reassure the patient. I'm just going to go with a real-time video here just to show how it actually happens. Is the video clear to everybody? Yeah, so this is how, as you can see, there's the patient out there, and yeah, here you can, I just want to show, just want to forward that. Yeah, you can see that once you click on files here, you can literally write anything, you can draw anything on that file there, and then you can send that across to the patient. So that's how you can do your prescription. And this is the third chat, as you can see the window. This is how you send the link on the right hand side. You send a link to the patient. And the third window out there is you get a relative from any other area if you want, or if he can log in into that window. So that's how it is. And like I said, advantage, you can record. Now, just moving on to the last, like consulting the prescription. Like I said, if you have an app, you're doing it through a browser, you can type it directly and digitally sign and send it across. But if you're not having the app and you want to just do it at home in a simple way, what you can do is you can just write your prescription on paper, sign it, take a picture of it, and send it across to the patient. I think that will also work well. A word of caution is if you're seeing any new patients, please do not start topical steroids. I would say definitely avoid. As and when you feel you're not able to manage the patient, refer the patient for a physical exam and refer to treating ideal patients. Now I've put that, I've like put that in italics, because what is an ideal patient? Maybe your post-op patient who's been fine for a couple of weeks or months and just wants some reassurance. Maybe your dry patients who need the treatments to be just continued. Your glaucoma patients who've been on good control for a while, something like that. I think there are a lot of patients who can definitely be handled by teleconsult, at least 50% of your OPD. The last is, if you have an app which is linked with an EMR, a colleague of mine just sent that to me like maybe a couple of hours before this presentation. So I'm not able to include a video of that, but the advantage is that this app is directly linked with an EMR, and I've put the email address of the person who is actually managing this. And Disha Hospital, I believe, is already using this. So I think if we have a browser-based application where it's directly connecting to the EMR, I think that will be very, very useful, because currently we are having the staff mail the EMR to us. They have home access to the EMR. Now, what's the future is if we can have, we can just take this one step further. We can have telemedicine on wheels, where we have mobile vans and, on bikes, where the optometrist is going and doing refraction, is dispensing spectacles. That could be something which we could do in the future. So just want to end with saying that tough times never last, but tough people do. Thank
you. Thank you, Kavita, for a wonderful talk. And before next is Mona, but in the meantime, I wanted anybody else to comment. Dishita, you have some things to say?
I would like to.
No. Sure, ma'am. Go ahead.
Yeah, Dishita, shall I?
Yeah, sure, ma'am.
Yeah. Dr. Kavita, since how long you've been using this app for teleconsultation?
We've been using it for the last 4 to 6 weeks, actually. We did face some problems initially, but now that we've gotten the hang of it, I think it's good. I do want to try out the new software, which is, the new app which I just talked about. I probably will try that also, which is linked with the EMR. So we'll probably do a trial or a demo with that as well.
Okay, so
this is through the web. We use Google Chrome. The one video she showed, and that one is through the Android phone app. And
okay.
The first one is ANT. Both of them are given us 3 months free offer. Later we have to pay. But we are charging, and there's no secret about it. We are charging 500 rupees consultation. And I have told, I hope Akair is on the online. He's looking after we want to start for the foreign countries and charge $50. But I don't know what's happening. I think so. I have given a direction to my hospital that all consultants and all ophthalmologists, that is whether DNB, everybody can do a teleconsultation, and also optometrists. And then I said we should be the number one telemedicine teleophthalmic consultants in the country.
What happens to the review consultation, sir? Sometimes you may require it within a week's time or something like that, cornea condition, something. And,
I take it for granted. I think we are doing it free. I think. What, Kavita?
Sorry, sir?
Do a consultation today, and a week's time they again come for a
review
consultation in tele. Are we charging? I don't.
No. We haven't been. No, we haven't.
We're not charging.
In the cornea, you may require frequent consultations. That's the reason.
I mean, we haven't been as of now because see that the guidelines I think are pretty fluid. We haven't really made something very solid as now. But I think now, as of now, we've not say a conjunctivitis patient wants to talk to me again in a week. We haven't been charging them again. We just kind of talk.
We both are getting the hang of it, the patients and the doctors. So probably it's a learning phase for both. So we need to get comfortable with that first.
Today I'm getting calls, and I think first 2 weeks, even today I do sometimes free. Money is not the point, but I think there's commitment from both patient, and also we are entering this in the EMR. The only thing is yesterday I heard on another webinar where the Sporus developer, he's telling that we should have an integrated, I'm not sure, it was integrated, one risk is I don't know whether somebody can hack your EMR. So I'm not sure. Anyway, we are now doing it as a separate. We do the teleconsultation and then enter in the hospital staff enters in the webinar. So that whatever, even if we give a drop, we take a photograph which is valid in according to medical MCI, where we can give a prescription. But we make sure that is we are already doing it for a video consult.
The problem would come when we get back to our routine practice. No, then we may not have this much of time to allot for teleconsult. Probably we have to keep a slot just for teleconsultations.
Yeah, I already planned. For example, when Kavita is there, whatever time, 9 to 5 or 9 the regular time, I think we will make sure that if there are too many consultations, there should be a 2 hours within that hospital time for only teleconsulting. So she will start now. Right now, I think usually she does 9 to 11 surgeries, followed by OPD. I think I have an idea which I'm doing now. That 9 to 11 she can do teleconsulting. In case she gets surgery, we'll do surgery and come back. And then that is all with a prior appointment, unless the real.
Right. So you have an idea how many teleconsultations are scheduled for that day. Yes.
My suggestion is each consultant should do at least 10 a day today. So 10 to 10 will be 100. So the hospital will get some revenue and we can pay the staff. This is my.
Yeah, sorry. Right now we're doing about 6 to 7 definitely per day, like each of us.
10 per consultant.
Yeah.
We have 10 consultants, 10 into 10, 100 a day. Okay, Dishita, you have something to say?
No, I think what ma'am just told about the telemedicine is very good, and the latest app that she talked about, that of course reduces a lot of work of separating, integrating. So,
Dishita, sorry for interrupting. I have a brilliant idea for the Young Ophthalmic Society, which you represent today in our webinar. Young ophthalmologists are having a problem like you after training. So why not you become a tele-ophthalmology consultant?
So that's the one thing. And the other thing, what I also was thinking about is once you start or once you go back into practice, like you said, ma'am may not have time because your appointments will increase. You can ask the junior doctors to start off with the telemedicine.
Yes.
So that's also a great way for us to start off.
Right. Yeah, I think good idea. So Mona is ready?
Yes, sir.
Okay, great. So we have Dr. Mona Sone from Zero India. I think yesterday Arun Gulani was asking what is Zero India. Zero India is actually the center dot of India if you do the latitude and longitude. And that's why it's called Zero India. It's near the income tax office in Nagpur. But she is in a place called Varda. And Varda is world famous because of Gandhiji and now because of Dr. Mona.
Thank you.
Off to you.
Yes, sir.
You can share your screen.
Good evening all. I'm Dr. Mona Sune and today I'm going to talk on how to practice in COVID-19. In today's scenario, the whole world is in the fear of this COVID-19 and as a healthcare worker, we are most at the risk. So we all need to adapt to these new situations. But then if you want to practice, you need to practice safely. See, Delhi, I'm practicing since the first day of lockdown. Of course, initially there was a lot of fear, ifs and buts. But for the first week, mostly, I have done telemedicine through WhatsApp video callings and then sharing pics transmission. Though the shutter of my hospital was open, but yes, from the second week, I'm practicing daily, of course, by limiting the hour hours to 3 only. But now we may extend it as the just guidelines have come 2 days before, according to the and of course it is to be done according to the COVID cases loads in your area. If you are in a green zone, you can practice, but of course by you can raise it by step only. So we all need to follow some guidelines given by different health authorities like WHO, CDC, AIOS, and IMA, ICMR. But now we all know that the COVID-19 is what it is, how it gets transmitted, which is from human to human, and through droplets, aerosols, fomites. And as an ophthalmologist, we are all at risk due to our close proximity of the work. The well-known example is Dr. Li Wenliang. You all know of the fact. Then what is the action plan for the ophthalmic setup? So we can set up some standards operative protocols to run the hospital, in which it may vary from a big hospitals to a solo practitioner, which can be divided at the 3 levels. And role of administration is our aim is should be at reducing the number of patients according attending the hospital to avoid overcrowding in the waiting areas. Till now we were dealing only with the emergencies, but as per new guidelines, we may have to start elective work, and we need to increase it step by step. Of course, it should be more on a need based. Urgency or need can be determined by your own judgment and always should be considered. And you can wisely use electronic medias for spreading the information regarding the hospital strategies, change of the timings, and hospital operating protocols, as every day the dynamics are changing and nobody is know, and we all are verging to the situation. See, these are all by FB post which I posted from time to time regarding the hospital strategies and about the disease information. And you can see the first post is on the 16th March. It was just before the lockdown, when I was not even aware of the lockdown, but though the conjunctivitis cases were increasing that period. So I posted if it is related to COVID or something else. Then we can divide our practice or in the, our hospital that according to area, before the entrance, waiting area, and your consultation room. So before the entrance is signboards displaying the information related to hand hygiene and cough etiquette should be displayed. Make sure no one enters with the footwear, including your staff. You should provide hand washing units outside the waiting area and make it compulsory to all the patients and attendants with the, along with the patients. Wearing mask should be compulsory for everyone, and attendance should be allowed only with the kids and the dependents. Then waiting area and registration is the most important, as the sitting arrangement in the waiting area should maintain an ideal distancing criteria of the group. And you should, in each case, you should know the fever of history of fever, then traveling occupation, cluster, or contact with any COVID suspect or a COVID patient. Then case consent, which is provided by the AIOS or any local authority with the complete postal address, and contact is taken in each case. From address, one can know whether the patient belongs to any hotspot. In such case, ask your staff to inform you. No data entry in the registers can be done in the system, and it can be done later on. And money should be collected directly into the poly bag without touching the digital or digital payments can be encouraged. This is my waiting area, the one visual display, which this is the NGO which I work for, and this is area where we can see the distancing and proper taking of money in the poly bags, or open door of the chamber. Then the triage on the phone, which is the first crucial step in protecting the doctors and other patients from exposure. And you can avoid the walk-in patients and reduce the number of patients in your hospital. But I will not discuss, as it is already done by Dr. Kavita. But in future also, it will be very helpful in planning the surgeries and planning the surgeries and giving them appointments. Then about personal protective measures for the doctors and the staff. As far as the personal protection to be wear in OP, head cap, 3-layer mask, N95, respirator, face shield or protective eyewear, and unsterile gloves should be enough. OT gown in OPD should be a personal concern, and you should have a PPE kit in the stock in case of emergency or dealing with high risk case. No use of public transport should be allowed to the staff. Rather, till now there is no public transport is available, but very soon it will be starting. So you can ask your staff not to come by public transport. This is me in my consultation room. Then come through examination room. Only patient should have an entry except for the kids or dependent, and the protective guard or a barrier on slit lamp should be there, and slit lamp cleaning after every patient with the spirit should be done. Keep minimum conversation to lessen the contact period, and deal all the patient of conjunctivitis as a COVID-19 suspect and dispose them fast, as keeping the prescriptions ready, which we commonly prescribe for your conjunctivitis patient. Only soft copies of the old prescription and blood and radiology report should be entertained, and use of new prescription for each patient is to be done. Then stop doing non-contact torimetry as it generates aerosol, and if at all needed, you can go for replenishing torimetry and sterilize it every time after its use. Procedure like sac syringing, dilation, gonioscopy, and visual field should be done, but if really they are mandatory for at least next few weeks, you can do that. Avoid AR or routine refractions and direct ophthalmoscopy. And patient with a fever having ocular emergency should be attended with proper PPEs on, preferably in a different examination room. Then comes to environmental sanitation, and it is the key factor to all this COVID era. High touch surfaces areas like should be cleaned every year with 1% potassium hypochlorite. Then electronic devices and chair handles to be cleaned by more than 70%. Actually, less than 70% alcohol is not indicated. It should be more than 70% only. Then fogging of entire hospital at least once in a week should be done. Decontamination is also very important after doing all the work. These gowns, cloth masks should be decontaminated with 0.5% hypochlorite. And after reaching home also, you have very important to do, complete a bath and cleaning all your keys and mobile every day. It's a tedious, but now you have to accept and adapt. Then staff education, sensitizing them by putting all the necessary information on the hospital WhatsApp group. Various protocols and action plans should be shared regularly. You can make groups of and reduce the staff per day. Then make groups, the responsibilities can be divided and shared on the group. Then mask etiquettes and doffing and donning should be learned to everyone. Then SCQ as a prophylaxis, actually it is not recommended now, because it has no action on the critical enzymes of the viruses. So it is not better not to take as a potential risk of cardiovascular diseases. Then OT sterilization, it can be divided into the air sterility, OT area sterilization, and instrument sterilization. And air sterility is the most important, that air circulating in the OT is free from the virus, and OT area sterilization in the instrument sterilization will be going through a regular protocol. And what extra probably can be done can be shared. I think the most important in maintaining the sterility of air is air handling units, and to maintain the temperature and the humidity. Now, these are the standard guidelines for the temperature and humidity. And to be very honest, nobody knows how this COVID-19 will behave as far as the temperature and humidity is concerned. Otherwise, there shouldn't be a rise in the cases as far as our Vidarbha is concerned, as the temperature had gone above the 40 degrees centigrade. And the temperature within 21 degrees centigrade plus minus 3 degree, and humidity between the 20 to 60%. should be ideal. And so if we haven't measured humidity yet, this is the right time to do it, because if your OR has been closed for many days, and at least you keep running your air handling units and exhaust fans regularly before starting the OR, and temperature is taken care by the air condition. Then air quality. This is something that is very important to maintain a positive pressure inside the OR than the surrounding. It means that the air from the OR doesn't go outside as it mixes with the air it's outside. The current AIS guidelines and the discussions in the webinar seems to suggest that probably after each surgery need to stop this positive pressure, which is in normal scenario. We always try to maintain that the outside air should not enter the OR, and will probably need to relax. For example, if the we meet the asymptomatic carrier of and he breathed out lot of viruses 20 to 30 minutes in the OR, we don't want that air to go out, and that air in the wetting area and the nursing counter spreading everywhere. So that many experts are suggesting to relax this positive pressure ventilation just before the end of surgery, so that therefore the gap of 20 to 30 minutes between the two surgery. The rationale being the effect of the positive pressure goes off, the air exchange, the air doesn't go outside, and then you can again run your positive pressure building devices, that AC and this air humidifier, air handling units. So nobody knows the correct answer, but I think we want to maintain still the positive pressure as far as our air is concerned. Then the laminar airflow. Till now it is said that it is ideal, but in COVID scenario it is found to be very dangerous, as the flow of air is directly to the operating team, and if you meet the COVID patient, then whole of the team is getting infected, as this, it will make a big aerosol. And then we have various air handling units, again the HEPA filters. AC, again, I don't find it contraindicated. The problem of the COVID is the size of the virus is 0.1 micron, and it can pass through any pores of the HEPA filter or any base system you have in your OT. So chances of virus keep circulating is the main worry. These AHU filters should be cleaned and replaced regularly at 3 months and 5 years. Then OT sterilization and should be done as standard guidelines. This is what the air handling unit or air sterilizer at my place. OT sterilization has no specific guidelines for as far as the COVID is concerned. So we are going through the regular protocol, what we are doing now. Yes, autoclaving, actually the proper documentation at each time is mandatory, so that we know that each time has the instrument and the trays have passed the autoclave test, so that if something happens wrong, apart from this COVID area, the entire system of your hospital, and you never know how the stand of the patient will be there in these such situations. Then culture swab and should be sent every monthly. These are the specific guidelines given by the AIOS, that surgery should be a daycare, X-rays, chest, plus minus. I don't know how we are going to do it. But again, avoid general anesthesia surgeries, as it creates a lot of aerosols. Then all universal precautions as usual should be taken. Then minimum number of staff in the OT. Then there should be a 20 minutes gap between each surgery. And the protocol-based disinfection of the OT should be done after each surgical procedure. Then elective surgeries. Yes, we can, but obviously we need to know what is the scenario in the next 15 days, how the COVID cases loads are there, in which area you are situated. According to that, you can proceed step by step. Then, so with this situation, we don't need to change the standard protocol of the sterilization, but make sure if it is done in a proper way. And I hope if there were closed, we all did sterilization at least twice a week, so that now they are ready to use. Don't know how to avoid positive pressure at the end of surgery by risking and contaminating the OR. by increasing the chances of endophthalmitis. As we are using our gowns and caps and mask, gloves, I don't think there is need of wearing complete PPE for at least as far as the anterior and posterior segment surgery is concerned. But yes, of course, in oculoplasty and trauma surgery, when there is you are expecting the blood spillage, you should have this complete PPE. Then you should avoid running the multiple tables at a time. And if you are running the two tables run only one table at a time, and use everything new for each patient, as the serological disease can transmit, and we have to limit our number of surgeries at least for a few more weeks. Then we have to accept this new normal, adapt it, and act. Thank you.
Thank you, Mona, for a wonderful presentation. Kavita, you want to say something?
Presentation, she's covered a lot of points. I only feel maybe about her. She said that you don't need to wear PPE during anterior segment surgeries. I would like to disagree.
Oh, only N95 mask, eye wears, I think cap and gown is enough for anterior segment. What I feel, but it can be different.
To the panel, I would like to disagree there, and I feel for any kind of surgery at this point, whether it's anterior segment, you're operating so close to the mouth and the nose, we definitely need to wear a PPE. And about elective surgeries, Dr. Natarajan, would you like to comment about whether, because Mona said that we can start, or would you like to comment on that? Like, when do you think would be the right time to start?
I think I'm waiting for a AOS guideline, and I think nobody has still said. As I mentioned in the institutional webinar, Dr. Shubhadra Jalali said, why do you want to call this as elective surgery? And she suggested that it's a need-based surgery. Somebody, as an eye surgeon who has a cataract, who needs vision for treating a patient, he should undergo surgery. And that is nothing like emergency. So need-based. So that will be post-COVID. And regarding the OT, I think there's a guideline given by AOS. And I would like to follow AOS, one, because that if there is a problem, somebody pulls you to court, there is a guideline which will support you, because every lawyer is picking up points what you have not done. So I think, Mona, you have to be protect yourself to protect for your future. I think one of the first webinar, the legal consultant, a senior lawyer came from Bombay, and he said in next 5 years there will be cases that are during COVID, and I think that time nobody is going to tell you what good you have done. Everybody will find out what bad you have done. So I think we have to protect by law in every angle. Yes. And at least our institute, we have Dr. Suganti Iyer, who's a medical legal consultant for us, and she is part of is deputy medical director of Hindu Hospital. So whatever protocols they have, and I keep talking to all hospitals, Kavita talks, our consultants talk, so that we want to know what is Arvind doing, what is Elvi Prasad is doing. So as an institution, as a group, today also I went to the hospital and I told, first, most important for me is protect yourself. That means you as an anterior segment surgeon, I think you should know what should protect you, and whether the gown is enough or not. I think we have to follow everybody. I think that way, instead of creating a controversy. I know you said you prefer, but I think we should do here. We are open to so many ophthalmologists all over the world. I think we have to ask them to follow their guideline, their society's guideline, so that medical legally they are supported. The rule is different in US. Arun is back in there with us, and I think maybe Arun, you can comment, and I'll ask the next. I think who's next? Rishita is the next to go. So you can keep yourself ready. Arun can comment on the anti-segment elective surgeries or whatever need-based surgeries. And when do you want to start? And also about the precautions during cataract surgery.
So I totally agree.
The question also was whether you need to wear PPE while doing cataract surgery. And also, when would the right time would you feel to start elective surgery?
You know, it's amazing. We all have the same questions. As you know, I just got to my institute first time in now 6 weeks, 6 to 8 weeks. And we're going to look at all those things with the staff and make a plan. I totally agree with Dr. Natarajan. Number one is your own safety, your staff's safety. luckily, most of us anterior segment, we don't really have emergencies as such, right? So that is first priority. Second, best part of this whole thing is it's not a closed system. Usually doctors are advising patients, right? There's such a disease going on, do this. Patients are now on the same Google as you are. So it's very easy now. They know a lot already coming in. They're like, hey, doc, do you know about the remdesivir medication on TV last night? Like, no, I was sleeping. Cannot say that anymore. So I think patients are also so well educated. Half your job is done because they will come in with masks, right? So in fact, I'm encouraging my staff to, on telephone today, as I said to you, and I'll talk to you in my talk later, each one has unique scenarios of their practice, but patients are already coming knowledgeable. You don't have to raise the intensity of there's a problem going on. They know it. They also are leaving their house only if they have to. So I think it's a great time. We are all together, very high knowledgeable. And I agree, you have to be careful, have to go overboard. That's the only thing, because we don't know the treatment yet. There's no vaccine, there's no treatment. That'd be my take.
I agree, Dr. Gulan.
And Dr. Madhvi, you want to say something?
I was just thinking that Dr. Mona is a very brave doctor. She's been working all through the lockdown phase. So maybe because of that, she's much more courageous. She says no need of PPE. But we are all, I think.
I want to say this. I wanted to say this. I think nobody, I don't think the courage is the right word. I think she's duty conscious. And she told me, I'm a single doctor and how do I eat otherwise, she told me. I think beyond that, I think the question is confidence. And the second is I told her, just because of confidence, you should not make a mistake. It is like me. I think I'm an aggressive surgeon and I want to do so many things. But still, when I went to the hospital today, my next building has corona. The hospital, the next building. Yesterday, that old lady who had a chemotherapy went to Tata Cancer Hospital, and there was a little panic in the hospital. They said, "Oh, next building is sealed by the municipal corporation. The whole building is sealed." And I spoke to the two government officials, luckily, who are close to me, Dr. Sanjay Oak, who is part of the municipal corporation in KEM Hospital. Government has employed him, the CM, and then Dr. Shashank Joshi. Both said, we are in forefront. We are treating COVID positive patients. We are treating them on ventilator and the same precaution. Unless it is 1 meter and you have a droplet, nothing will happen to you. So first you be confident, Dr. Natarajan, and don't spread fear. The way you are asking, are you afraid? He said, I'm not afraid. I said, I want to protect my staff. He says, yes, that's good. So don't give them confidence. Don't give them overconfidence. And I also told them, whoever wants to come, please come. Knowing the matter, then I asked him, should we inform the patients that the next building has COVID? He says, no. Everybody can see, and I learned one thing in the institutional webinar that I want this to Dr. Arun to see that. You should see there's an app called Arogya Setu made by private but adopted by Government of India, which I myself have entered. An institutional webinar, I think Dr. Rajsekhar from Bangalore said, I think they are insisting every patient to enroll. The idea is if the patient is enrolled in the Arogya Setu, in the mobile, and you're on the Bluetooth, and it'll keep asking you questions, and you enter properly. Everybody in the government knows whether you are COVID positive or not, or whether you are, when you're moving around, it will tell you that this area is a hot spot, this area is orange, and here there's a COVID patient. And I think it's very good, amazing. I think I'm happy. First time IT, the headquarters is India, and India is on the forefront in COVID. And I think this sort of technology is very important. Today morning, I went to the hospital and already there are about 16 patients, they told me. 10 patients have gone home, 6 are there. So I suggested to them, make sure the relative sits in the car, have the mobile, and we're thinking of including QR code. So we want to reduce the human interface and use either robot or electronic. So I think we should not be courageous here. We should be wise here. And I think we should appreciate Mona is having the experience. And I think it is like somebody thrown into the ocean and you have to swim, and then she's doing that, and she's doing it wonderfully well. And I will only request us to follow the guidelines so that you are protected, your staff is. And not only that, I think I told her to put the photograph of, she did a camp, and I was against it. Then she said the police has organized the camp, and they are following the physical distancing, they are following the mask, the hand sanitizing, and there they distributed 50 patients over 8 hours, and each patient, each constable or police was checked whole day and many days, and each day one ophthalmologist was going. I think amazing. I think Varda is doing wonderful, and she didn't put the photograph. I think you should have put that cam. I'm not suggesting to India because we have a foundation, and all my staff are living in the Dharavi, and I really don't know how to protect them. And Dharavi is hot now, a hot zone. So with this, I think Dishita is probably something like a debut performance. So I'm happy to introduce Dishita, who's Miss Bangalore, and mother is a Miss Bangalore, and she's Miss Ophthalmology now. Yeah, yes, Dishita.
Thank you for that wonderful introduction, Dr. Natarajan, and also thank you for this wonderful opportunity. I'm just going to start off with my presentation. Yes. So all of us are in the times of Corona, and I, as a young ophthalmologist, I want to let you know what I am doing and what are the challenges that I am facing. So none of us would have thought of being in a situation like this. It's sort of like a nightmare, or we're living a movie of sorts. So what I feel right now is I'm absolutely pointless and useless at this point in time. And why so? Because I just finished my fellowship exams. I wanted to take a couple of days off, travel, and then start looking for jobs. But soon after my exams, the lockdown was announced. So there go my plans, all plans haywire. And while all the senior doctors here are discussing how to start off their practice, how to cut down on staff, there's so much uncertainty, a lot of sleepless nights for all of us. But really, let's take a step back and ponder how bad is it? So as students, I'm sure all of us, or even regular people for that matter, haven't we all cursed traffic? That we spent less time in traffic signals so we could go home and spend more time.
Dishita, you need to share your screen.
You have to share your screen.
Oh, I
see your presentation. No.
So you go from your first slide.
Okay. All right.
So all of us were impressed to look at you. We forgot the screen.
Oh.
Yeah, better now. Yeah.
Is it visible?
Yes.
Yeah, you can make a full screen.
Yeah, I'll do that. So sorry for that glitch.
No problem.
Yeah. So yeah, like I was saying, I kind of feel pointless, and about my personal situation, about how I just finished my exams. And I'm sure I have a lot of colleagues, friends, and a lot of other people who are also in the same boat, and a lot of doctors. So it may not be right to say the same boat, but we're all facing the same storm at this point. So like I was saying, we've all really thought about sitting in traffic, wasting time, how as postgraduate students or residents, we always wished for fewer duties and to have extra days off, or just, to have enough time to learn a skill or two, or to start off on the hobby that we'd always been putting off, or just basically to strengthen our knowledge. So now that we have all the time in the world, let's take a step back, relax, rejuvenate, and think about what we can possibly do about this situation. We may or may not be able to do a lot, but we need to accept things the way they are. But for me, my biggest concern right now at this point is, when am I going to operate? And this is the time where I should have started operating more numbers, should have gained more confidence, but it just looks like my skills might be rusting at this point. So that reminds me of what my mentor taught us in the first day of my fellowship. He said, you must observe keenly. And what I've realized over the years is observation is actually so understated, and it's so powerful. And in today's day and age, we have YouTube, we have the internet, we are living in the digital world. So there's really no excuse for us, to just sit back and laze or complain and give excuses. So go through a lot of, you have the opportunity to go through a lot of videos, learn keenly, observe keenly. And another thing that is very important is, once you go through these videos, it's important to visualize them. And that's something I have actually been following even during my fellowship. You visualize what you're going to do, so you recall it. And even the days before my surgery, I go through it over and over again just before sleeping. So it also helps with sleepless nights. So all this is fine, but what we also need to do is physical conditioning. Just like how athletes are not born overnight, neither are great surgeons. And since we do have time on us, we can start off with little things. We may not have access to full setup of wet labs, but you can set up your own wet labs at home. Like you can try to make a Rexis on the skin of a boiled potato or a boiled tomato, improve on your skill and speed each and every day. And the other thing you can do is try a lot of exercises to strengthen the small muscles of your hand so that your motor skills improve, your dexterity improves. We all know that we need a lot of hand-eye coordination for surgery. So go ahead and indulge in your video games once in a while. All these are very important to prepare ourselves. And of course, we know there's a plethora of webinars going around every day. So we have all the opportunity and all the time in the world to attend any of them as we like in the comfort of our houses. But what's important for us is to choose wisely and prepare for the road ahead. We need to know what webinars to attend, and we need to prepare, learn the protocols, because of course things are going to change in the future. And this is the best time for us to be equipped with all this information. So choose wisely, learn from information that is relevant. And so this is something that I actually came across from a psychiatrist recently. There's something called the Zoom fatigue syndrome, and it's actually real. It's not something that is just made up. So it's basically what happens because of exhaustion from face-to-face digital interaction. A lot of people start off their days with work calls and then webinars, and then you have Zoom calls with family and friends. So at the end of the day, you're actually more tired than a regular day. And why is that? Because it actually takes a lot more strain on your brain, because you're more conscious about how you look on screen. Every little move of yours is being seen. And also you have very less physical activity. So there's a lot of lactic acid being built up. So watch out and don't fall prey to this. So if you're bored with all the seminars and webinars, make sure you publish. I, in fact, personally have been not very fond of publishing. I, in fact, found it very tedious. But thanks to my mentors, I've finally submitted a paper, and they say you publish and flourish, or if you don't publish, you perish. So this is a good time to start off with that. And of course, if you don't want to be involved with the subject, take a step back, relax, focus on yourself, make plans. Don't just get used to the laziness. It's very easy for us to get used to the lazy routine of the life, but set a goal, declutter, you can exercise, work out. They say a sound body houses a sound mind, so it's a good time to exercise. So once you do all this, it may not be that bad. So I'd like to end by quoting Muhammad Ali. He said that champions skill and will. But what's important is that the will should be stronger than the skill. So in these tough times, it's important for us to be strong-willed, and we should know that this too shall pass. So thank you all for listening.
Thank you, Dishita. Kavita, you want to comment?
Yeah, wonderful. I think she's wonderfully summed it up. That it's and I think someone also said that if you don't use this time and come out with a new skill, then definitely you haven't made use of your time. So there's so much of time you can like go back to all your hobbies, like take up courses online courses for dancing, there's online courses for creative writing, and anything that you probably wanted to do, this is a good time to have done that. And it's great, and congratulations to you that you finally wrote that paper and submitted it. So
thank you. I must thank my mentors, Dr. Sheetal Brar and Dr. Sri Ganesh, for that, because if not for their push, I may not have done it. So yeah.
Mona?
Agree with the Zoom webinar fatigue. I completely agree with that, because there would be a webinar and there is a pre-webinar check the day before, and then you're attending some other webinars. So I completely agree with the fatigue with the Zooms. I'm literally on Zoom for almost 1/4 of my day, which I think, yes, I need to rethink that now. Great. So Dr. Gulani, would you like to comment anything, sir?
Arun?
Well, I liked everything you said, Ishita. One, you said about visualization, which is very important, the way I like to teach and talk surgery. Second thing, being positive. Three is I absolutely believe, and I've said this and I'll say it in my talk too, during this lockdown, lock in. See actually what you want and were you in balance with your life before. If there's nothing to change, congratulations, you're done. If you do need to change, great time because you were forced to meditate during this time, right? Wonderful job. I love it. If it's sending a paper out, that's great. Whatever your goals were. Most important thing I like to say, there's another, Kavita, right? These Zoom. I mean, it's become amazing. I speak in my sleep now. It's unbelievable. The next webinar I've been asked to do is about life and stuff. And what I'm saying there, again, is the same thing. People talk about life beyond ophthalmology. I say life within ophthalmology. Why do you have to be beyond? That means you are not doing something fun every day. If you love to sing, sing while you're operating. If you love to dress up while you're seeing a patient. So to me, all those things are very vital. The misleading things that business people teach us. Don't forget, you're smarter than anybody out there, right? I keep repeating this many times. You were so smart in a college that you became a doctor. Remember, people celebrated that. That means even if you didn't realize, it was a big thing. Then among doctors, you become an eye surgeon. Remember, that's like the fewest seats available, correct? So really, you don't need anybody's advice. Just look in. There's nobody you need at this point. And I hate it when people keep saying, we need help from here and here. Just look inside. There's no one more powerful than you. Another thing, many people may be watching you. You may be their inspiration. So if you break down, it's over. You cannot. For your patients, for your family, for everybody, enjoy yourself. These were 2 months of vacation, but you know what? If you felt nothing changed, or just like another Saturday, Sunday, it means you were perfect in balance. Didn't need to do anything. You can still learn dance after work, 5 o'clock, while you're working, noontime. Your patients will love you. And Dr. Natarajan does that. I know that.
Yes, and Madhavi and Mona, you want to say something before Arun comes in?
It was a wonderful talk, Dishi. And I just like the way you are telling us that to be a positive in this lockdown. And we are also utilizing post-working period for such wonderful activities as cooking, painting, so many positive things to do. And well said, Dr. Gulani, that he's saying that it's beyond, not beyond ophthalmology. It's with the ophthalmology we have to go for all these things.
Yes. Because remember, you chose this profession. You chose this profession. Remember, no one forced you into it. So if you made a wrong choice, it doesn't match your IQ. I won't believe it. We clear? Will not believe it. So with that.
Madhavi?
Yeah. I like the new thing that we've learned, Zoom fatigue syndrome. Vision has now become Zoom fatigue syndrome. It's very true, because whenever I post the forwards that such a webinar is there, the people in my group, they keep saying, Madhvi always forwards about webinars. So they all must be fed up with this, they must be getting the Zoom fatigue syndrome. But then it's up to us. We have so much of time and so much of choice. We are spoiled with choice, we can go and select whatever we want, our subject of interest choice, and then we can, very nice, we can engage ourselves in different way. I like the innovative thing of potatoes and tomatoes and doing rexes with those boiled tomatoes and potatoes. Yes, you can keep your hands deft. I do the same with vegetable cutting also, keeping my hands deft. Because you need to do that, right? We are all into microsurgery. So we have to keep ourselves engaged. That's right. It's a very good talk, Rishita.
Thank you.
Next is Dr. Arun Gulani, and I want to present Dr. Arun Gulani as Arun Gulani, not doctor. The reason is, as he already mentioned, he's a great ophthalmologist. He's my neighbor from AEM Hospital, and I think I'm very impressed with him. I learn a lot from him. So one is how to present yourself. I think all my positive thinking slides says stand up tall. It shows how confident you are, and he's one thing. And I think if you see him, any posture, whether he's today morning's Facebook post, he's sitting in a small like a balcony, like a steps, and then having the laptop, but he's sitting erect. And I think that's what life is about. As an ophthalmic surgeon, you have to sit erect. So I made a beautiful chair, operating chair, so that I all the time stand erect, as a sit erect. The same thing is standing tall. It emphasizes that you're positive, you're emanating. So I think like that, he does fashion. And I remember when I was probably Times of India covered in a big full-page article on me and Naresh Trihan and 3 more like cardiac surgeon and orthopedic surgeon. And only ophthalmologist was me. And I think he's the only one who appreciated, oh, you're in that league where they put a photograph of mine dancing in a disco. And the fellow took photograph from morning, from my gym to the operating, the OPD, OT, and many interacting with patient and walking in the road. And finally, he put the photograph which he took in the late night in the disco. And many friends criticized, and that was in 2005. Hey, how can you be in the fashion, man? And when you're an eye doctor, you have to maintain yourself. Then I learned from Arun what's wrong, and we are human beings, and we are intelligent human beings, and we are not, and we are better than many in the world because we are intelligent enough to. That's why we are taking the fine surgery. And even though refractive surgery use computer and everything, I think, but the man behind the computer is the surgeon. That's you. And I think you make wrong entry, you can't blame the machine. If any court case is there, it will not go to the computer or the elastic machine. It will come to you. And I love his talk. He says he's interested in giving 20/20 to a vision and not the procedure, whether it's a corneal procedure or whether it's a cataract procedure or whether it's a LASIK or a repeat surgery. He says, I want to give back 20/20 to the vision. And I think we are in 2020 and we are locked down to think back. And yesterday I told Arun that I have only 2 more weeks to do what I want. So with this introduction, I want to show Arun. He's not a showman. He's like Raj Kapoor is called the showman of the Bollywood those days, and later Shah Rukh Khan. And a lot of people compare me in ophthalmology, but I think the best man is Arun. And Arun, here, all yours.
Oh, please. Thank you. So actually, you finished my talk, so I can leave now.
Oh, you carry on.
Okay, here we go. Thank you so much. Always a pleasure. So I'm going to share my screen now. Can everybody see? Yes? Okay, lovely. So first of all, I'd like to thank you for the invite. Again, it's really because I have never read a book. So that's a big thing. It's a big surprise to many people. And I don't believe in reading because I believe all of us have a GPS. We are already wound up with a mission. And all we have to do is release ourselves in life. Education actually dumbs us down. So, but we have to go through it because we must. So that's my take on life. All of us have a direct mission and keep moving in that. You'll see that as you know, when you go on a highway, even in India, I'm sure when you're driving, if you're in the wrong, and you're in the wrong direction, you still have to go forward because there's no exit, right? How does that feel? Pretty horrible. You're still driving at full speed, but you know you're wrong and you know you have to turn around. That's what I think many people do as a mistake. So, and how's that feeling when you know on the right highway and you step on the gas? That's an exhilarating feeling. And that is truly your innate direction, which all of us have. So I like to just follow that direction. I don't follow any rules. It's a pleasure. The privilege that we all have been eye surgeons. I think it's one of the greatest professions, not one of, I'm just biased. It is the greatest profession on planet Earth, helping people and enjoying yourself. So my point today I want to talk about is thriving beyond surviving during COVID-19. To me, yes, this is a very difficult time. All of us are involved. I myself volunteered my time at hospitals, did things, but in a way, I think it's a great time to look in. I really want to thank all of you at Aditya Jyot. I call it Twinkling because for many reasons, it's always been a pleasure. Also, thank you so much for letting me operate on my late father over there. It was a real pleasure. And every time we meet Dr. Natarajan and me, we find time for lunch or something at any meeting anywhere in the world. So it's always a real pleasure seeing you all, Kavita. So what I like to do is I actually made a video for all of you. And in this video, what I want to show is actually what we did before COVID. And as COVID came, what happened, and then how we went home. And today is actually the first day I'm back in my institute. And I want to share with you, I didn't follow any rule. Again, just follow your heart. And everything I do, what I like to I repeat here for people who are not here as I got in, I don't like to say look beyond ophthalmology. I say look within. You're already doing an amazing stuff. Wake up in the morning, dress up, go. We're dealing with the cleanest branch of medicine. Everybody agree? You don't even see blood. I mean, come on, guys. It's the most gorgeous branch. And you deal with amazing technology and you see the patient hugging you next to you. I mean, can anything compare to that? Look at our other doctor friends. Got it? And so how lucky are we? And you sit and operate. Come on, you're listening to music. I mean, where's your complaint? So with that kind of profession, we must be in it full steam. To me, fashion is important because that's my second passion. It's not like I dress up for someone else. It's my own pleasure. So if you like anything, just do it while you're at it. And the office is yours, remember. Play the music you like, color the wall with polka dots, whatever you like. It's your own office. Have fun. And the patients will always love you because they like a comfortable person. They're not going for appearance. They're going for a comfortable, confident person. So here's a video. I'll share with you what happens here. So this is every week, a Friday in my institute where patients fly back to different parts of the world from all over. And this is the only time the whole groups come together because the way I practice, which is also important for today's talk, I see only one patient per hour. Basically, if you come across the street of 40,000 mile, one patient an hour, I personally refract them 40 minutes per patient, et cetera, et cetera. Fridays, when everybody's leaving with all surgery, this is the fun thing we used to do. We'll have to change now. And lockdown, I mean, look inside and see, are you in balance? And can you do something better if you are not in balance? So here we are. My pleasure always, doctors visiting, learning, teaching, a lot of fun every day. Different kinds of surgeries, all techniques. Fashion is my passion. So in the evenings, I used to do that. Patients from all over the world, really, really my pleasure. I used to love their hugs. Patients doing fun stuff with me, breaking their glasses, stamping on it. These are doctors out of surgery. My point here, I keep emphasizing to patients and doctors in particular is, you see these reactions. In fact, a recent article of mine came out in Ophthalmology Times. I said, show me the patients. How many of you have seen Jerry Maguire? Lovely. So they stole my line 30 years ago. Even as a resident, I used to say this, show me the patients. My point was to encourage colleagues and bring them immediately to reality. I'm not impressed with you putting stitches in the eye, hanging the lenses, pulling on vitreous. I'm not at all impressed. Show me that patient during that maneuver was smiling and talking to you. Show me that immediately post-op on the bed, they're hugging you. And next day they come dressed to kill, ready to fly, and you're confident to let them fly. If a surgeon cannot show that, do not show me the surgery. That's how strong I want to take this. Statistics are just ways of how you can fudge numbers. Remember, you can have a bigger range and you can immediately make a graph look good. But the human being who has paid for their surgery and is on camera taking a selfie is the only indication of success in today's world. How many of you agree with me? All of you?
Yeah.
Also, even while we are sleeping, remember, these patients are writing about you, right? So all that's in my article, please review. So those are all my important things I try to say. Therefore, when I show you this or any surgery, you'll see my patients are in it. Real people, in the most demanding patients in the world, in the world's most litigious country, who are posting on Facebook. Why are they doing that? Because below everything is a normal human being who was just waiting for your help. That's the way we have to see patients. So these are doctors, again, visiting. My fun thing about teaching. Sorry. Continuing the video. So slowly, all these things, the fun going on all the time. Again, like I said, doing fashion while you're doing it, not outside, while you're doing it. Having fun with your patient, letting them do whatever they want with you. It's a real fun time. Please see your post-ops yourself. Traveling, teaching, let's see what happens to that. So this is what happened then. My hugs became fist bumps and distant hugs, if you can see here. This is just before closing, then home. More home and more movies, took off my suit completely. Then webinars, the fever starts. And then here I even started cooking to show how premium cataract surgery confusion, a question that I get from every corner of the world with so many brilliant eye surgeons is, doctor, what lens? It's a totally irrational question. So I was teaching while making an omelet of how ingredients, lens is just an ingredient, you are premium. Lens doesn't make your surgery premium. Imagine this. You're a husband or wife and you cooked a phenomenal meal and your husband's on the table with your guests and the guest is a super meal. You say, oh, she's okay. It's that special thing that I bought her that makes the food awesome. Won't you want to slap him right there? Yes, everybody, same emotions. So that's the whole point. See how confused doctors are in calling a lens premium. I'm putting this lens for you. Now look at the other side of it too, where again, you're getting harmed. If the patient doesn't see, first of all, if the patient sees 20/20, what are they going to say in their night parties? Oh, this is because my husband gave me this anniversary gift. He bought this phenomenal lens for me. That doctor, I don't know her name. I don't know, but that lens, that's why I'm seeing amazing. So first of all, you got no credit. Now here's the other side of this. if they are not seeing perfect, what do they say? Oh, that doctor, brain dead, man. Despite my husband spending so much money on that amazing lens, she couldn't make me see. Right or wrong? So you see how wrong this system is that majority of doctors are following. How do I know? Because their patients are here and they keep questioning me, these doctors. Doctor, what lens would I put in here? What lens would I? I'm like, please, you're a master chef. There are 40 lens technologies to choose from. Everybody, how many lenses are approved in the world? Anybody? 83. All right. So why are people giving these options like a waiter? Platinum, gold, garbage. What do you want, Mrs. Smith? Have you all seen this? Patients confused, you are confused. Now the lens goes in, then you're waiting to see what happens. So please get off that track. That's why I did this video. I showed how ingredients you can put as a master chef, and that revision recipe is what you should be famous for. Cooking for 2 hours, calling your surgeries nightmares, right? And cooking for 2 hours, but nobody eats your food and it smells like garbage. You failed. I don't want to know what pressure cooker you used or what technology you used. Nobody ate it. So that's how we should see our surgery. It's the impact. So I love what Ishita said, visualize your surgery. So actually I did this during the COVID thing, did an omelet and putting ingredients to show how to work it. Of course, more webinars. Then I did a masquerade challenge, basically making masks at home, but I made a global challenge and we recently gave the award with 9 judges from different countries to help people understand how to make masks, made a kind of a donation drive out of this in the country. Again, things that we will remember doing related to COVID. More webinars from early morning. Did you guys know this? I did this during COVID video. Did you guys know gin and tonic? How many of you like gin tonic? Kavita? No? You're saying no? Anyone else? Ishita, where's anybody? Gin tonic. So how many of you understand, first of all, the debate still goes on, hydroxychloroquine. Everybody knows that, right? You know, chloroquine came from quinine, came from the Jesuits' bark in South America, all that stuff, you know. All right. Now.
Yeah, tonic water has quinine.
Amazing, right?
Yes.
So gin and tonic actually was invented for the British soldiers who took over Tipu Sultan's army, and then they were dying of malaria. So how many people know this concept that tonic water actually contains quinine? So that's the reason I did this fun video that day. So there we are with that. Then I also did my fashion stuff. Kept on designing. I've designed a whole line of colors for this spring, now summer, and actually did my own modeling outside my home because you have to keep it going. So kept doing that stuff. Oh, sorry, it keeps going back. Very important here, please. How many of you have heard people wearing pajamas below their jackets just because webinars is okay? So never cheated. Didn't cheat even once, I promise you. Very important.
No, I am doing it.
Right? I love it. I love it. I know this group won't do it. I know this group won't do it.
No, I'm working on shorts.
Then I even reflected during COVID. Very important time to reflect on what you're doing. This was a snail I captured a week ago on the beach. You know, it was about to slowly come out. The water comes, then it goes back, and that's when I, made fun of it, saying, we're back in lockdown. And then I saw a turtle 3 days ago, slowly heading out, and that's how we need to start our practices, slow and steady. And of course, we need to get back to the same love we had, maybe with slightly different aspects of taking it. So that's a short video I made for you to show how we need to keep doing what we did. And you will really not remember this time other than you were given so much time to keep doing what we love. As far as today's topic especially goes, I really believe look in, stay positive. All of you have brought up great points. In fact, as I just walked to my institute, I'm seeing these N95 masks that are here. I'm seeing these shields that have come in. If you can see, a lot of stuff has now come in for extra protection. I do believe we have to take that extra precautions just because of the patients that we see, because they're not an emergent patient, and you really don't want any site to go down. Factors that people may have to revive their practice, universal practice. Patients will start getting oriented first. What do we do? First, they have to come out of the house. Do they have a job? Is my eyes more important? What about my parents who haven't seen for a month now, right? Sick parents or something. So they'll assess their priorities, necessities, financials. For us doctors, we are faced with a maze of regulations, staff reorientation, adaptation, but maintain your reputation and results. That's very important. Can't let that go down. Now, in our practice in particular, it's a very unique practice. 80% plus patients of mine come from out of state, out of country. So that's another burden on me in the sense that I'm conscious of those things. Actually, 7 or 8 patients actually stayed back in the US. I fixed their complications of their previous eye. They had RK complications, LASIK, keratoconus, very complex things. They did very well, and they thought this will go away in a week. So they've been texting me every 2 weeks, doctor, when is my other eye? So that's my personal issue with my practices. I have to work with that, make sure that they get work and help. Second is travel now. With so many patients who travel to me, how do I work on that? Can they land on time? When I send them back, is their surgeon's office open? If the office is open, can they see a patient like this? Have they changed their protocols? So those are practice-specific things. I'm not changing my scheduling because that stays the way it is. It is an elective practice. I'm going to, again, maintain the distances and protections and surgery, like was very well described here, Dr. Mona. And action points. Very important from us point. What have we done in this meanwhile to stay in touch with patients, newsletters, social media? It's really gratifying to see patients texting you during this time, asking for your help and telling you how amazing they are seeing. Also, we are starting a triage video conferencing concept where I'm going to video conference these patients. All I have to do is see them, look at their topographies, talk to them, explain, and keep them ready when it's ready to fly. So that, and then staff also, please stay in touch. Remember, your staff needs to understand in these times, and I always say this, it's important to lead by example. So they realize this is a mission. They're not coming back to a job. They must be basically impatient to come back and join the team. So that's the other important thing I want to talk about. So with that, I'd like to say, let's all come back with a bang, and any questions, we'll take it now.
Great presentation, Arun, and I think it's really wonderful. I want to apologize that I forgot to call Madhavi to present, but before Madhavi should be ready next. And I like, in the meantime, Dishita to go through the questions and Mona to keep it ready, what question to ask. Madhavi, you get ready. In the meantime, I think brilliant presentation by Arun, and I think Dishita to respond. This is for the young ophthalmology. You're just starting a career and you have a new path now to follow.
So firstly, I've always been a big fan of Dr. Arun Gulani. Right from the first time, you also, right from the first time I saw you at the Bangalore Ophthalmic Society conference. So since then, I've been following you closely. And all the things that you say are so relevant. As doctors, I have non-doctor friends who look at us as nerds, as people who don't dress up well and things like that. So what you're saying is so true. Enjoy what you do, and it actually makes a big difference. That's very important. The other thing is, how we deal with our patients. What you said, and of course, I follow all your posts on Facebook. It's very motivating for me as a young ophthalmologist. So thanks a lot for sharing them, firstly.
Yeah. So even to me, as a young ophthalmologist, Arun is my mentor.
What he said, follow your heart. That really makes the difference. Follow your heart, and you get what you want.
I'm following Arun from '92, I think, when he joined KEM. Somehow I came in touch with him, and then I think I'm following him from that time. Right, Arun?
It's a real pleasure. Again, thank you so much. What is important is all of you, especially young ophthalmologists here, it's very, very easy to follow business models that others put in place. Here's what I tell, I'm always about empowering doctors. Maybe something that motivated me. All of you remember these movies where doctors come out of operation theaters with, spectacles and pot-bellied, and they come out and go, I tried my best, I'm so sorry. Remember? Yeah. I used to hate it. I want a doctor to come out with their shirt buttons open and flex muscles and go, we did it, man. Let's go. So why don't doctors be like that? That's what I want. That's the basics that I want. Patients already think of you as a rock star. Anybody wants to challenge me, go into a grocery store where your patient is, see how they treat you. They look for you like you're like a movie star. Very important. So don't change that pattern. You're a doctor. Remember, you worked so hard and you're amazing underneath. Just because you read books doesn't mean you're going to forget all that, right? That's step one. Two, the way I like to teach surgery. Jump off the cliff. Make sure you cut off the rope. Make sure you cut the rope. Then you have only one option: fly. You feel, oh my God, if I let this go, it's over. And that's what business teach you. That's why I don't read those. So the point is not to be like others. See, what do consultants do? Have anyone ever looked into this? So many consultants come and advise you, right? What you should do. Has it ever occurred to you that you're smarter than them? Yes?
Yes.
Everybody. Make you exactly like your other guy in town. They bring you, they spend up till there. You got to buy this, you got to do this because that guy's doing this, guy's doing this. Now they made you equal. Now they make you spend more to beat that competition. First of all, they took you from your individuality and made you mediocre. Now they are fighting with you at mediocrity level.
Yes.
My take on life of business. You are individual. If you doubt me, go into the mirror. You'll never find someone who looks like you. Isn't that amazing? Isn't that amazing? You're unique. You're amazing. So do not let someone tell you what to do. Shut your eyes for a minute. In lockdown, this COVID, I hope, never comes back. Look inside and go, my God, I could stay awake 72 hours. I could, without food, I used to sleep on a bed at night during emergency, right? All of us have done it. Beeper going off, right? Come down and do this and that. And in all that, you got to be mentally perfect. You got to look professional. And next day when you come to the OPD, does anyone forgive you because you didn't sleep for 3 days? Do you get a hat? I worked and so what? You don't, right? So which soldier can compare to a doctor? Why do people say doctors on the front line fighting? No one can fight like a doctor. Come on. Does that make sense? A doctor is way beyond. All we must do is, every right comes with responsibility. Make sure you perform for your patients. Don't fool them. Don't advertise. Don't call your surgery robotic. There's nothing robotic about it. I give you in writing, laser doesn't improve cataract surgery outcomes. I said this when the lasers came out before FDA. I wrote a whole supplement for CRST. It is useful for certain parts. Now, this is another important part. I got a lot of questions on this. Doctor, do I have to invest in this technology before I start practice? I'm very scared. I'm like, no, look in the mirror. That's your Bruce Lee. Stop complaining about I don't have my Terminator gun or Rambo knife. Pick up the chair and bang it on someone's head. Just take your tools, your own hands. And here's very important, doctors. If this hasn't decided, and this cannot feel it, this cannot perform. The way most people teach is backwards. Let's do surgery. Let's do 10, your 11. I'm like, no, your first patient is your mother. Be very astute. Your first patient has to be 2020. And don't look for easy cases. How many of you have seen doctors teaching you like this? If you're doing a premium cataract surgery, look for a guy who's okay, who's not so driven, who's not type A, who tolerates. How many of you have heard this? Please raise your hands. Anybody? Everybody. What are they basically trying to say, Kavita? One line, right? Find a patient who's stupid enough to handle your mediocrity. Right or wrong?
Right.
Why, as an artist, would you want to find someone mediocre to appreciate your art? You want a type A person, driven, absolutely demanding, because only they will appreciate and Ishita go on Facebook. Remember, again, don't have to tell a patient to write or make them write or give them a Starbucks card or makeup. They should want to. Therefore, if you see, at least on our whole thing, Facebook, because we don't advertise at all, everything is written by patients. That's the power. A lot of places I've sent my white papers to, they send it back to me. Dr. Ghani, we can't have patients' photos in it. I said, okay, you will then wait for 20 years because I'm not coming back to you. I'm telling you where the North Pole is. If you still want to struggle going east and west, your choice. I'm not changing the way I teach. You cannot have a higher level of accountability than, quote, a fully paid patient with high IQ, taking a selfie, putting it on their Facebook saying you are amazing. That is proof of success. Everything else can be fudged. Agree?
True.
To build that, start with your first patient. Start the relation with them. They trust you. It's what I call a $1 billion check. You repay that in a currency called vision. All of you are vision corrective surgeons, 40 techniques, not smile, LASIK, cataract. That's like hamburger, burrito, and masala dosa. You're not a waiter. What can I give you, ma'am? You're a master chef. You decide looking at the patient's 4 things: anatomy, physiology, optics, visual, potential. That decides what lens, what surgery, how you're planning it. So that's a talk for a different day, but that's my take on how we need to be. Most of you are, so you don't need to change anything. And that's pretty much it. So COVID doesn't change anything for you. You just looked inside and went, oh my God, I'm so happy and lucky to be in this profession. All right?
Yeah. So I think Mona is by practicing from day one, like as she said, from March, I think she's doing daily. So with this, I want to introduce Dr. Madhavi. So Madhavi is an active member of the Women Ophthalmic Society of India. And we want Madhavi is practicing in Vijayawada. She originally from Mangalore, Kannada girl. Yes, Madhavi.
Yes, sir.
Yes.
Yeah.
Yes, yes.
Fine. Shall I start my presentation?
Yes, yes. Go ahead.
Am I audible? Is my presentation visible there?
Yes, yes. Make it full screen.
Okay.
Make it full screen.
Okay. Good evening, everyone. At the outset, I would like to thank Professor Dr. Natarajan sir for having me here in this interactive webinar. I think a lot of my talk is going to be repeat. There's a lot of overlap. Nevertheless, let me just tell my perspective. So if things were supposed to have gone, just a moment, screen. I don't know. Yeah. That's what I'm doing.
Okay.
I'm doing it, but then just a moment. Is it moving? Yeah. Are my slides moving?
No.
No?
No. Now it's moving.
Yeah, now I think it's...
Yeah, it's fine.
It's okay? Fine. Okay, so let me go on. So if things had gone as per how we had planned, probably we would have got back to our normal routine today. But unfortunately, COVID is still raging. So we have another 2 more weeks of extended lockdown period. In this time, we all have to remain calm and positive, stay safe. And I think we can utilize it to look in and prepare for the testing times ahead. During the last 6 weeks, what I have been doing is I have remained connected with all my patients, because most of them have been post-operative immediate or just a few months post-operative, or my glaucoma patients. They had their own concerns, so I have always remained connected with them, though not a proper telemedicine, tele-ophthalmology mode, but nevertheless, it was a telephonic consultation. Second, I have always remained connected with my staff as well, because they have a different set of concerns altogether as to whether their job is still there, what are the plans when they get back, is the salary going to be paid, their working hours going to be extended. There are a lot of apprehensions. So just you have to reassure them that we are all together in this. And also we need to keep updated with the situation and the practices in the local area, in the state, or maybe the nationwide regarding ophthalmology and general practices as well. We need to be informed. Since we need to keep ourselves promoted, we have to start doing some amount of social media marketing also. That's really helpful in the days to come. And though we have closed down the facility, all our equipments are very expensive ones. We need to maintain them as per the company protocols, the gadgets and the equipment. So maintenance has to be done. And we also need to think of what are the avoidable expenses in the post-lockdown period. So my thought process is that initially 2 weeks from now, like that's what happened yesterday and day before, I was getting a lot of phone calls. Me or my center manager or my colleague, we've been getting a lot of phone calls asking scheduling for an appointment. So we had to tell them, wait, we still don't know. So I expect the same thing 2 weeks down the line. People are going to call, and initially there's going to be a real increase in numbers. Probably patients will flock. But after that, we don't know how the situation is going to pan out. So maybe there'll be a decrease as well. So we need to be prepared for that also. An initial increase followed by maybe a plateau phase would be there. So during this time, once we go back, what are our concerns? Immediate concerns are going to be regarding safety measures, planning day-to-day practice revival, reinforcement and implementation of the protocols, and maintenance of equipment. Safety measures, this has already been told, but I would like to tell a few points regarding patients, staff, and the doctors. Patient safety. Many institutions probably they have appointment system already, but in the place where I practice, we have at least 80 to 90% of my patients are walk-in patients. They don't really take an appointment. They know my timings and they walk in at their convenience. So I need to, we need to encourage henceforth, at least, for at least another few months or maybe 1 year, that would be the way down also. We need to encourage appointment-based patient follow-up. And when they come, you schedule the appointment so that it will be convenient for the patient, and also social distancing can be maintained. And surgeries, anyway, we give appointment, but even for the OP, I think we need to encourage that. Promote teleconsultation so that the number of visits can be decreased. And also, if they are not really conditions which we need to see face to face, then probably we can avoid the crowding in the clinic and take consent if they do come in. Taking of consent as per the protocol is very important. Coming to staff safety, it has already been mentioned. All of us do have adequate staff, but in that also, all of them may not be required, because in my facility, if it's a smaller facility, then spacing is a problem again. So if all the patients, 100% of your staff also are there and the patients also flock in, then social distancing becomes a real difficult thing. So in that case, you can, considering safety of both the patients and the staff, you can just keep adequate number, maybe 50% of your staff, and then that will avoid crowding. And you can also encourage multitasking. Continue all the hygiene and sanitation practices which were there pre-lockdown, continue them as religiously as before. Doctor safety is of paramount importance. Also give importance to any comorbidities and the age consideration of the consultant. So basic minimum we need to have, whether it is a COVID or non-COVID case, gloves, mask, and goggles is a must, and the shield at the slit lamp shield is a must. Taking all this into consideration, we need to now see how to revive the practice. Whoever is there in a patient telephonic consultation, see that you can schedule them for a follow-up visit. Patients who are really planning for a surgery, they've been asking for maybe a second eye surgery or a refractive surgery, you need to schedule them. But here a word of caution, we need to see, is it really safe still? So that is a thing I wanted to discuss in the question answer session. Do we need to take a consent for everybody? Whether they are just like how we do viral markers, do we need to do it for COVID also? I don't know what are the guidelines we are going to get, how practical it is to get everybody, and do we need to get ourselves tested also, because we are the major carriers, and whoever you come across could be a positive carrier, potential carrier. So we need to be careful. So we have to schedule surgeries depending upon the safety and the urgency. I'm talking about the elective surgeries. Also, we can revive our practice by extending the number of working hours. So if we had a 9 to 5, probably we can extend another 1 or 2 hours, so that it's for mutual benefit to the patients as well as the doctors, and public holidays and Sundays can be utilized as well. Doing all this, still we have some concerns. Patients will definitely take some more time to decide on their procedure, because all our procedures are going to be elective procedures. Refractive surgeries may be deferred for longer duration of time, and the premium packages may be deferred. And branded opticals also, patient may not really prefer that. They will say, okay, no, I will go for the ordinary ones, and all your multifocals may get converted into your monofocals. So we have to be prepared for that. Having said that, we need to be still genuine and considerate, because that's going to pay us in the long run, because we have to consider patient point of view as well here. So how else can we manage the cash crunch here? Probably we can stall the buying of newer equipments, hiring of more staff, and maybe marketing activities can be put on a stop. So we can work out a win-win situation for both patient and for us by working out new packages and scheduling surgeries in such a way that we can work out on the consumables. Plan refractive surgery on fixed days so that the machine running cost would come down. We can also promote group practice for better utilization of staff and our space, and reducing the marketing expenses. Whether most of the hospitals would be NABH accredited, but however, if they are not, we all have some amount of protocols in all our setup. It may be a small setup or a huge institute, but some protocols are there. All of them we have to reinforce. Now we need to have a role of a policeman as well, and see that there's no complacency, and all these protocols are into force again. Maybe a few new protocols also may come into force because of the COVID. All this will only help us to ensure safe and OP as well as surgical procedures. It's very important, because we don't know how this is going to, all these things have to be assessed probably on a fortnight or a monthly basis. How it's going to evolve, we don't know, but we have to take a call from time to time. And maintenance of equipment. As soon as the lockdown is lifted, doesn't mean that you're going to have a lot of surgeries, no, not that you're going to have a lot of your refractive procedures, so your machine may not get the full run immediately. So even at that time, we have to maintain all the equipment as per the company guidelines. So see that the AMCs, the CMCs, and the insurances are in force. And also when we buy our consumables or the inventory, we have to plan. Probably we did 100 surgeries a month previously. We may not be doing so many. Maybe it may come down to half, 50%. So accordingly, we have to plan so that, finances will not get blocked. Coming to the OP protocols proper, it has been already covered, but I'll just tell a few of my points here. Basically, we have to consider the maximum safety for all the three I mentioned, that is the patient, the staff, and the doctor, cost factor, and the feasibility. Are we able to follow it? See, for a different setup, the rules may be different. For a small setup, a single practitioner, it will be different. And for an institution-based thing, it is going to be different, which has to be applied accordingly. So what are the areas we have to monitor and give importance to? Even before the patient enters, that is before the entrance, at the reception area, at the optometrist or the consultation chamber of the doctor, investigation area. These are the areas we need to monitor. And what are the ways we monitor regarding the personal measures, safety measures, and the cleaning. And all this can be achieved only if we train ourselves and our staff. So before the patient enters, you have a display board. If your facility is a huge one with multiple floors, maybe at every landing, every floor, you can have a display board with all the instructions given properly in the local language as well as in English, so that everything is told to them correctly. And there should be a shoe stand so that all the footwear is left outside. A hand sanitization or a hand wash has to be done before the patient walks in. So at the display board itself, we need to have these things written. Like how Sir was telling, we should have a Arogya Setu app, which is really useful. Ask the patient to leave all the belongings outside, remove the shoes, hand wash, and wearing mask is mandatory. It is mandatory. Don't allow a patient. Don't be complacent with that. You have to tell the patient, please wear and come. Patient, and see that attendant is not encouraged unless the patient really requires, an elderly patient requires an attendant, or if the patient is a child, then an attendant is a must. Otherwise, avoid an attendant. And even when they come for surgery, we have decided that we're going to ask the attendant to wait in the car, in the vehicle outside, and only the patient is going to come in. And all the reports, like anyway, telemedicine is going to be the way forward. So probably everything can be in a soft copy already be handed over to us before the patient comes. And give strict instruction to patient not to lean anywhere, not to touch anywhere. It's very important. So in the reception area itself, if the area is large enough, we can have a separate kiosk for a history-taking thermal scanning and consent that everything is done. There has to be SOPs given because all of us are new to this. We don't know, there are simple things, but very, very likely that we are going to overlook a few things. Even I might forget, I might keep touching my face and things like that. So we have to make it a practice. So SOPs are to be there at every station, like at the reception, at the optometrist, at my table, everywhere there has to be SOPs so that we follow them. Once it becomes a habit, then there's no problem. So even the money payment, like how Dr. Mona had shown, transparent polythene bag is a better thing. You have to put into that. And for 1 week, we are not supposed to touch it also. Even better would be online transfer. At the reception table, a small thing like even a pen that we don't share any patient because it's a very common thing. Just give me your pen. We'd like to fill up the form. No, don't do that because we are so used to it. We have to be very careful of even this small thing. And after everything, there has to be a cleaning that has to be done. And on the table itself, there should be a printed sheet of the hotspots in your local area, so that if the patient is coming from that area, that particular area, which you're seeing in the consent form, then you have to be alerted. The doctor and the optometrist, everybody has to be alerted that there is a possible patient who is coming from the hotspot. So we have to be more careful. So in the reception itself, we'll have the staff SOPs having all these simple things given, nothing big, and all of them know it. It's just that they have to see that they are following each and every step of that, asking for a proper address, not only of the patient, of the attendant. You have to remember here two things. The patient who comes during the OP consultation and who comes for the OT during the surgery may be a different attendant. So you need to know the address and everything, the postal address, even of the patient attendant who's coming along with the patient. So assess the area from where they are coming and see that you're aware of the hotspots from day to day. Because every channel on the TV is telling you where you stand, where your locality is on that particular day. So be aware of that. Coming to phone calls. Before the patient comes itself, most of them are going to be appointment-based. So you're going to one particular person can be assigned to answering the phone calls. So they will tell them properly what they're supposed to do. And furniture and decor. Avoid carpets. I mean, this may be practical, may not be practical, but as far as possible, you keep chairs so that or benches and keep a proper spacing, at least 2 to 3 meters away. Depends upon your facility. In case you can't do that, then you schedule your appointments in such a way so that there's not much of a crowding in your OPD or in that particular floor. No article should be there on the tabletop. and no magazines and newspapers, copy vending machine. There are small things which we have taken for granted. All that is going to be changed because that's going to be the new normal for us. Air condition. See, like how Dr. Mona showed, all the doors should be open so that there's a proper ventilation. The cross ventilation should happen. Air should go out. And ACs, I don't know, in my area, summer it's a scorching, Vijayawada is otherwise called Blazewada. It's so hot here. But without AC, I don't know how we are going to function, but we have to make do with that. Keep all the windows open, or if at all you have to use an air conditioner, it has to be a window model and not a central AC. For the staff attending the phone call, I was telling you, while you're answering itself, attending the call, you ask them if there is any complaint of fever, then you try to avoid. You ask the patient to first go to a physician, get a consultation, see that there's nothing more serious, and then only they can come. Because unless it's an ophthalmic emergency, probably our consultation could wait. And if it's a routine refraction or change of glasses or just a post-operative tapering of medication, we can always do a teleconsultation. Personal hygiene measures for doctors and for staff are again even we need to have the Arogya Setu app. And as we come, it's an exercise which we have been following just once in a week or twice a week. We have been going, or for the last 15 days we've not gone at all. But whenever we went, it was a protocol that we followed. We directly go to the changing room. We wear a different set of clothes because you have to have a cap, mask, and OT gown, gloves. We have not used a PPE per se, like how she was telling. I don't know how much it is required, but we have not been given, nor do we have require it right now because we are not really seeing COVID positive patients, but every patient could be a potential COVID positive. So if we know it's a positive patient, then a PPE is a must. And also, if we are having longer working hours, then we have to see how we are going to take a break for the meal also. Otherwise, what we have been following right now is we work continuously from say maybe 10 to 2 and don't take a lunch break at all. Go directly, close your working hours at that time and go away. Or a second set of people can come at the post-lunch session so that you don't take a break and stay there. Personal water bottles have to be used. No, you're not supposed to have any articles on your table. You have to avoid all those in a consultation room also, and see that how your staff is traveling. That is also very important because if they're coming from, right now we don't have much of a public transport, but if they are using public transport, again, that has to be taken consideration into. In the consultation room, this could apply to even for the optometrist room. Optometrists, all of us are so used to having an optometrist, so most of the history taking or the examination is already done there. So we have to avoid a few procedures. Only what is required will be done. In a consultation room, keep just one chair for the patient. If they have a habit of moving from chair to chair, no, don't do that. Just keep one chair, and a protective guard has to be there at the same time. After every patient is seen, we have to chin rest, the forehead rest, and the shield has to be clean. Minimum conversation. And if you see a conjunctivitis patient, because we have different studies saying that even conjunctivitis could be a late form of presentation or maybe the first form of presentation. So we need to be aware of that and wary about it. And only soft copies. If the patient, they all have a habit of coming with a entire folder of all their cardiac, orthopedics, and all the reports, and maybe their past ophthalmology reports also. See that you avoid, unless it's absolutely necessary. You don't look at any of the older prescriptions or the reports. So what we need to avoid practically are touching of the eye and the adnexa, aerosol generating like NCT or AR has to be avoided. Even Shiorsen, if at all we need to do a IOP check, applanation is a preferable one. Dilatation also is preferred to be done at home if they are scheduled for any surgeries. And the gonioscopy and visual fields also should be avoided at least for the next 2 to 3 months, 2 to 3 weeks. We need to see how it's going to evolve in our scenario. Absolutely no is a direct ophthalmoscopy or a sac syringing. To summarize, only complaints which are considered emergency or causing repeated concern to the patient are to be addressed, and accordingly we have prioritize. Otherwise, everybody is going to call up and tell we want to come for a checkup. No, but you have to decide whether it requires a priority consultation or not. Otherwise, we can wait and ask them to come at a later date. So this has to be again reviewed and reassessed maybe after 2 weeks or a month and modify accordingly. Coming to the cleaning part, this is again very important. Everywhere, every 1 hour, you need to clean the floors, the door handles, the knobs. These are small things which we don't think of. It almost might look like we are obsessed, but then we need to do it. The cleaning is very, very important. It's not the fumigation and the widespread spraying cleaning that is recommended. It's more of surface cleaning that is recommended with the hypochlorite or a bacilloid or even soap water is good enough, and more than 70% alcohol-based solution you have to clean, and even the walls up to 9 feet. It has to be done as a religious practice. And the person who is doing the screening, your housekeeping staff, they have to be very careful. They can't clean. They'll be anyway wearing the gloves, but they can't go and touch every surface after that. They have to be very, very compliant with that. And we have to keep seeing that. It's very important. And washing. As we finish our, before we get out of the facility, we need to again go back to our domestic clothes, whatever we came in, the civilian clothes that we came in, remove the theater dress or whatever we have on there and directly put it for washing. It has to be soaked in hypochlorite solution and it has to be washed and dried in a open area, preferably in a in sunshine. And face shield also has to be dipped in the hypochlorite solution and we can use it the next day. After every patient, we need to clean, and at the end of the day, we have to again remove it. Coming to this, all this can be achieved only if we work as a team. And how that does that happen? We need to have some mock drills of doffing, donning, cleaning, everything. And this can be done by repeated classes to the staff as well. We need to sensitize them. We need to tell them. As Sir Dr. Gulani was telling everybody, the patients are very much aware of the situation. In fact, they come and ask us, have you done this? Have you done that? Even our staff, they're also scared because they also can be infected. So everybody is quite sensitive to the issue, but we need to keep reminding them and we need to form a group and see that all the protocols are shared with them and we have to delegate each person and they're answerable. One particular job has to be done by them and SOPs have to be followed strictly. So once we survive this initial setback with caution and careful frugal measures without compromising on quality, I mentioned that once again, without compromising on quality, we are bound to harvest very rich dividends. Just a matter of time. So brighter days are ahead and stay home, stay safe. Thank you all for your patient hearing.
Thank you, Madhavi, for a wonderful talk. And I just was reading the latest May issue of IJO. The cover page says, spread facts, not fear. So I'm glad you mentioned doctors and medical staff and patients are afraid. And I think we'll go to the question and answer session, which will address to all of us. I think Dishita and Mona, you can take over.
Yeah. So, of course, there are lots of questions which have come in, a lot of them regarding telemedicine. So, a lot of them want to know what is the cost of the app, how to get started, and what are the legal issues which come with the app, with telemedicine.
So, I'm a life member of Telemedicine Society of India. You can go through the website, Telemedicine Society of India. The founder of Telemedicine Society of India has got a company called ANT. And I think he has given us, he worked with Arvind Hospital and Shankaranathala, and they are based in Madurai, and they have their app, and they have two modules. One is free, which we are using right now, and there's a payment mode. That means, sorry, I don't know how it works. I have not gone into because it was a difficult, as a head of the institution, it was a difficult proposition to make the consultants, the IT, the front reception, the nursing staff to accept. Now, finally, Kavita is the expert. So I think the cost probably Kavita is not involved right now, but the ease of working, I think she's doing very well. So I think there are hundreds of companies will be after you if you just call some company, they will eat your head because they keep on calling. Even now, in spite of we are having in the website 2 companies, there are so many companies daily call me. And I think you take one software, I think there will be plus and minus. So we have taken this. And I have taken a decision that I will only follow this. And I think Kavita can add. Kavita mentioned to me that AOS is also working with some company to produce advice on which company or software to take. Kavita?
Yes, about this, if they want details, I can just share my screen again and they can probably just share that.
Okay, sure.
So in the meanwhile, Dr. Natarajan, they also want you to share the slide about the sodium hypochlorite concentration and what you're using for the OT. So if you can prepare for that.
Yeah, I just want to add here on this last line, I've written the contact details, whoever wants to make a note. As Sir said, like for the first 3 months, for sure, right now it is complimentary. They're not charging us anything as I talk to the person. Later on, I think whoever was interested can contact this and find out. As far as the legal issues about telemedicine, I think as of now during the pandemic era, we really don't have much of a problem. Like I said, if we use caution in starting steroids, don't dilate patients whom we've not seen for new patients. And I really don't think there's any legal issue. In fact, the government of India has said that telemedicine can be done. Dr. Natarajan, you can add on that, sir.
Yes. I'm actually, yeah. So I think the telemedicine, Government of India has given a direction, which is there in the website, and All India Ophthalmic Society did a webinar on telemedicine and first week of April, which is there in the YouTube and also in the AOS website. And I think as we are talking, there are things dynamic. I think there are some cases, court cases as the PIL, where about testing this thing, and also in telemedicine. So I think they should have a consultant and ask for the go through the rules. And I think we are also following. There's also a consent form which is required. So I think we should go individually and go through that. And definitely AOS has got a telemedicine in the webinar. I know that. And this is a screen which has preparation of the 1% sodium hypochlorite solution. Probably you can take a screenshot. And I think AOA yesterday, Dr. Atul showed the same thing practically. There's a video prepared by RP Center in AIMS, which is also there in the YouTube, I think. So AIMS also has got a YouTube channel which you can subscribe. And I think definitely you can follow AIMS because the government institution. You can follow AOS and also any other ICMR this thing.
Okay, can I move on to the next question? It's also regarding telemedicine, but what they want to know is what is the scope of telemedicine for retina patients? How are they supposed to take pictures and things like that at this point in time?
It's a very good question. I wanted that I read about AO member where he has made ordered just a plus 20 LVA lens from the market, and he told the patient he did it on himself, where he took a selfie with a mobile phone with an adapter with the 20D, the cheaper lens. It's about I think he said that $30 for that lens, LVA lens, like a 20D, and then the tropicamide is at $10 there. And with $40, you can do a retina photograph yourself. That means put 1% tropicamide, no other thing at all, not tropicacil plus or anything, no phenylephrine, because with their old patient. He said he's a 65-year-old retina surgeon. He doesn't want the patient to come every month. Neither he wants to go to the clinic, which I'm also working with a company in Bangalore, whether we can take a anti-segment photograph and a retina photograph like this as like a selfie, or a relative who can take the photograph and send. Because in tele-ophthalmology, the original tele-ophthalmology, which we are members, and we are also member of the Telemedicine Society of US, where you need to examine the retina and the anti-segment, which is not possible now. We can only thing is, for example, today I got a call or rather an email saying that I went to a clinic in New Bombay, I have my OCT, I want your consultation. That can be done. But you have to have every time a disclaimer that you are based on that OCT, based on that, because you are not able to examine, and there is a limited diagnosis. And if you have a doubt and if there is a controversy, I think you should recommend better get an examination done so that you are medical legally not compliant. And I think our medical legal consultant said, if you are giving a diagnosis and you are not having any of this, there can be a thing that they can pull you to court. So either way, you have to be ready to protect yourself, and you have to have a good relation with the patient so that you don't give misguided patient and knowingly. And in case you have done something and you know that something is there, you call the patient and tell them we need to examine before you do anything. Because when you say a patient has a wet AMD and it's 1 day old, you need an injection. He has to come. So it has to be confirmed on the day of examination. And the only thing we can do is we avoid fluorescent angiography. We have at least OCT angiogram. So we can tell the patient to schedule an appointment, OCT, fundus photo, and do the injection so that one visit, everything is done and he goes back. And we did that for only one patient in this period where the patient was saying one night and the patient was losing vision. So the other teleconsultation where really you can examine the retina is right now not possible. And LV Prasad, Shankanatla, and we are doing this as a telemedicine where somebody can send the images, and based on that you can do a consultation, which is happening between the main center and the peripheral center when there was no COVID. Now during COVID, I think everybody is stuck. So if they go to some clinic, they send a photograph, you can do telemedicine. But I think telemedicine will have a future even during the normal COVID. And this is my dream. And that's why we had an Asia Pacific Ophthalmic Society we have. I'm a member. And the third meeting was held in September, where Google was part of it. And we are actually introducing that AI, which is embedded in the phone for diabetic retinopathy. We have trained illiterate people, that means school dropouts, in our foundation. And we have the first publication in the world ahead of Google, and we are in the top 5 in the JAMA last whole year. So we are proud of that. And there's a recent article saying the AI failed in Thailand because of the internet problem. And ours, we don't need internet, we don't need electricity. We charge I don't have any financial interest. It is made by Remedio in Bangalore and Medios in Singapore. The software is from Medios and the hardware is from Remedios, where we have done the study using it, and then which is now being used by Johns Hopkins. We are going to do it in Central America, South America, Africa, and also East Timor and Australia. Yes. Okay.
I think we can wrap up. Other questions are what Dr. Mona has spoken about, the laminar flow and the positive pressure. Maybe if you can just share your slides on the screen or the presentation.
You can unmute Mona and show the slide.
Yeah. And just in the meanwhile, Dr. Suraj has said that the AIOS has issued a guideline to avoid elective surgery. So this was issued on the 24th of April, and we haven't heard anything since then. So as of now, elective surgery is not recommended.
Yeah. So even in the institutional webinar, Dr. Atul said they're already doing any patient who's losing vision, that is AMD, diabetic macular edema, and or any like cataract, hypermature cataract or total cataract. So like that, they are doing emergency and urgent cases and not the regular. So that's why they want to defer, which is not being confirmed. I hope the AOS will come with even the IGO advisory is about April 15th or something. So now we are in May 4th, and I think we need a dynamic change in the SOP. So she has put the slide on a laminar flow and HEPA filter. What is the question, Dishita, to Mona?
Most of those having laminar flow. So what to do now? They are asking about the safety. Actually, recently I have talked to my orthopedician friend, and then one of the most popular intensivist in Nagpur, working in the ORES. So he said ki actually what is laminar flow is directly the flow of air is on the operating surgeon and the team. So unfortunately we meet with any asymptomatic carrier, then the virus will go on circulating in the air and directly will hit on the operating team. So he told me some options about that, to just shift to the table so that there won't be any direct flow, and it should be away from the door, and the waste part, and you can increase the fresh air loads by increasing your AC tonnage. And then again the one important is it's best to have a HEPA filters along with the AC. What the intensivity suggests now. So that they wanted to actually say that you increase your fresh air entry up to more than 50%, what we are getting now. So there is no such advantage of laminar flow, and there can be a disadvantage also in this COVID scenario, especially.
So I hope that question has been answered. Another question which Dr. Rashmi has put forward is, if COVID test is being done for all the patients, do you really need to have PPEs? This is I think for surgeries. I don't know what exactly she's trying to ask, but basically I think she means if all patients are being tested for COVID, why do you need a PPE?
Actually, he is my resident.
Okay. Yeah. So if anyone would like,
we are not supposed to, without patient consent, we are not supposed to even order for a COVID test. That's the problem.
Okay.
But for patient safety and for the staff and the doctor safety, or the patients who are going to come later, For all that, we are a little worried whether we need to do it or not. There's no proper consensus on that still.
Yeah, I think any more questions, Dishita? Because they called me and said they want to conclude.
Most of them are done.
Yes. Pardon? Somebody said? Okay. So anything else? So I think it was a great webinar, and I think I learned a lot. And I'm sure all of you are learned. And whoever is watching, in case we have not answered some questions, please feel free to contact us through anything, either email, WhatsApp, or even through Facebook or anything. I mean, Instagram, Twitter, all of us are available. And thank you, Arun. Early morning and the first day for Arun to be in the clinic, and I think it's nice of him to spend time. So I want to tell all the viewers that we are planning a fun, frolic, and something, one more F for in the next 10 days. And I want, me and Arun are planning, and I'm planning to involve the Bollywood star Boman Irani and some actors. So nothing to do with ophthalmology, just to say how to live life king size.
Wonderful.
Looking forward to it.
Yes.
Thank you, Arun. I think you have to unmute. I don't know whether you're talking. Arun? No, you have to unmute yourself, Arun.
Yes. Thank you so much for having me. It was a real pleasure meeting with all of you.
Yes. So thank you, Mona. Thank you, Kavita.
Thank you, so wonderful. Nice seeing everybody.
Thanks, Chanda Pharma and the background team of Aditya Jyot who are doing all this in the webinar. Thank you very much. I think we can go.
Thank you, all of you. Bye-bye. Stay safe.
Bye.
Yes.
Bye-bye.
You can stop streaming.